Hi, this is a video for the ED teams at Northern Beaches Hospital, describing our approach to the management of resuscitation during the COVID-19 pandemic. Resuscitation is an aerosol generating procedure, which means there's an increased risk of contamination to staff and caregivers. Because of the undifferentiated nature of our patients, we have to assume that when giving resuscitation, all patients in the emergency department carry some risk of contamination to the team, and for that reason, we'll be adopting these new procedures for all patients who arrest in any area of our department. As a team, we are experts at resuscitation, and we have a clear mental model of how we work together. However, during this period, we need to change some of our processes, and this might conflict with your muscle memory of how we normally do things. That's why it's really important that you're clear on how we're going to work before an emergency occurs. The underlying principles are we must use the fewest number of people to do the job well. They should be in the bed space for the shortest period of time, and we should work in a way that gives them the least exposure. For that reason, the most important principle is that no one enters the bed space without wearing PPE. It is very difficult not to rush into the bed space when we see a person suffering an emergency. But it's true to say that during a pandemic, there is no emergency that doesn't require the team to stop and protect themselves appropriately. You'll need PPE appropriate for aerosol procedures. This means an N95 mask, eye protection, a gown, and gloves. You'll either find this on the standard PPE towers, but there is also emergency PPE on each of the Resus trolleys. Here is our modified cardiac arrest algorithm. You'll find it in the team read file and laminated on each of the arrest trolleys. It's important to be familiar with it before you need to use it. Here are some of the important principles. We're prioritising early defibrillation. The first person to enter the room begins chest compressions once they've confirmed arrest. The second person applies the defibrillator when an early coach is performed. Leave whatever face mask the patient is wearing. If it is an oxygen mask, you'll need to turn the oxygen off at the wall prior to defibrillation. If it is a standard surgical mask, leave it in place. It's very important to send for the Lucas early. We want to get the Lucas device on and the person delivering chest compressions away from the patient at the earliest possible opportunity. Because the team is small, all team members will be needed to apply the Lucas device quickly. If you're not familiar with the device, please seek training from the clinical practice educators. Once the Lucas device is running, the preferred airway adjunct is an eye gel. Don't insert the eye gel until the bag valve mask with the catheter mount and filter connected are ready to go to minimise the time that there is an open circuit. Stop the Lucas device before inserting the eye gel to avoid pushing out contaminated air. A good seal is really important, so consider positioning the patient with the tragus anterior to the sternal notch and applying a jaw thrust as you insert the eye gel. Once the eye gel is in, ventilate at 30:2 by changing the setting on the Lucas device. Stand to one side of the patient and ventilate gently. The team can then continue standard ALS care. A secure circuit and viral filter is important to keep the team safe. All the BVM circuits on our Resus trolleys already include an extension, a filter, and a side stream CO2, but you should still check this before you insert the eye gel. The end-tidal CO2 sits in line behind the viral filter and connects the defibrillator through the port low on the front. You'll see a value displayed on the screen, but no box waveform. If there is no IV access, the preferred IV access is an easy IO placed in the tibial plateau. This is because it is furthest away from the head of the patient.
Mr. Smith? Mr. Smith, are you okay?
I'm okay. Hey, Kath, I'm learning with the team leader.
Oh,
We're
hi
just going to get our PP on team. That's right, Kath, a good round over. You want to come out, put an oxygen mask on and come in with get your PP on, Kath, that's right.
Okay, so visor, glasses, mask, down. Yeah, turn up, close.
Visor, face shield, mask, down. Fine, okay. I'm going to start chest compressions until you come in, Kath.
Okay.
Okay. And once after comes in, we'll do a rhythm check. And we'll get the pads on. You guys got that? Sarah, if you wouldn't mind getting a line in and set up an urgent BBG for me, please, and get the ultrasound ready, that would be great.
Julie, can I have some stuff for the ID?
Sure.
I'm going to get a chance to see the ultrasound once you've done the liquid. I'm ready to do a rhythm check.
Okay, so let's do a coach if that's all right.
Continue compression. Oxygen off at the wall. Yep. I am charging to 360. Hands off.
Okay, BF, that's shocking rhythm. Please defibrillate. 360,
Shocking
200.
rotation now. Continue compression. Oxygen on at the wall.
Okay guys, so we've got a man who's had a cardiac arrest in VF. We've done a shockable sided over. The next thing we're going to do is get the Lucas on. So if you guys would mind coordinating the back plate first. And then we'll roll, and then we'll get the Lucas on. And we'll start that continuous compression until the LMA is in, okay?
On my count of 3, roll the patient towards you. 1, 2, 3. Back, 2, 3. I'm getting you some pain relief now. Bring it around. Just move that strap a little bit. Okay, coming down that top. Yep, on. Yep.
Okay.
Next strap, please.
The next thing I'm going to do is get an advanced airway. If you've got the LMA ready with a background mask circuit. Good. So I'm just going to set the circuit, make sure the connections are on tightly. We've got a viral filter, 2 snaps, for a peak, a background mask, we've got an end-tidal CO2, and we've got an MMA size 4. Okay. I'm just going to move to the head end now, guys. That's right. Okay, so the sequence is going to be, we're going to turn off the oxygen on the wall cap when I say, then we're going to pause the Lucas and then insert the eye gel, then we're going to connect to the bag valve mask with the viral filter, and then we're going to restart the Lucas, turn on the oxygen as well. Is that okay?
I'm just plugging in the CO2.
Are we all ready?
I'm ready when you're ready.
Oxygen off at the wall, pause the Lucas,
Pausing Lucas.
oxygen off.
Yes, oxygen's off.
Okay, I'm going to carefully remove oxygen mask. LMA going in now. Okay, LMA connect to viral filter, open mask, restart oxygen, and restart Lucas.
Restarting Lucas.
You could bag at 12 per minute. Have we got an entitled CO2 traces? Well, yeah.
Coming up. And we've got an end-tidal CO2 trace.
If you could, and then if we're on 30 to 2, if you give me 2 ventilations from the side pack.
Yep, no worries. Thanks.
It's a rhythm check now. 2 minutes is up.
Okay, so, are you happy to do another coach and a rhythm check?
Yep.
The management of out-of-hospital cardiac arrest follows broadly the same principles: the fewest number of people exposed for the smallest amount of time, and procedures designed to reduce exposure as much as possible. Once the back call is received, the team assembles and dons the same PPE as described before. The doctor will go and meet the ambulance crew at the back of the ambulance and can take the COVID IVs with them, which is kept in the wrap area. Listen carefully to the ambulance handover to understand the pathophysiology of the cardiac arrest and to understand what interventions have already been completed. Carefully consider all the available information, the presenting features, the low flow and no flow time, the first end-tidal CO2 and the current one, the first rhythm and the current one, the number of drugs that have been delivered and the successive interventions provided so far. You can use the IVIS ultrasound to support your decision making. If with all this information you feel that there are no more reversible causes or interventions that can be addressed, and the length of the cardiac arrest suggests that the probability of an acceptable outcome is extremely low, you can pronounce life extinct in the back of the ambulance. Make sure the crew understand that it is our patient. We will register the patient, and it is our decision to stop the resuscitation. It's really important that this is communicated in a way that is appreciative of the work that the pre-hospital team have done to get the patient to this point, and in no way is this decision a criticism of their decision to transfer the patient to the hospital. contact the mortuary and make arrangements for the patient to be moved directly to the mortuary without bringing them into the resuscitation room. We have body bags available for this purpose. We'll register the patient and you'll need to write notes. We will be able to write a death certificate, and the coroner has made it clear to us that we do not need to refer patients if the presumed cause of death is COVID-19. The ambulance service have confirmed to us that they are happy with this arrangement. If you identify that the patient would benefit from further resuscitation in the emergency department, ask the pre-hospital team to bring the patient in doing chest compression only CPR, with the bag valve mask resting on the bed. Transfer the patient directly to the Lucas device, and with the pre-hospital airway in situ, we can go immediately on to 30 to 2 compressions to ventilations. Perform a coached rhythm check, and then when ready, carefully transfer the patient to our circuit, pausing the Lucas device as you do so. This is because our circuit will have an end-tidal CO2 for our monitor. If the patient arrives on an endotracheal tube, make sure the tube is clamped before transferring. If they do have an endotracheal tube, you can connect them to the ventilator and run at 10 breaths a minute with asynchronous continuous chest compressions.
Hi, is it alright if we take a handover?
Hi, sure. So this is a 44-year-old male. He witnessed cardiac arrest. He's had 3 shocks now. We got a ROSC, and en route he's gone back into VT. That's where we're at now. No known history.
Okay, so VT was the last rhythm?
Yes.
Okay, and so we'll have reversible causes there that we can fix. So we'll bring him in, we'll continue chest compression only, just leave the bag valve on his chest, and we'll get him over to the bed and onto the Lucas, and you guys out.
So the Lucas plate and bridle are already there.
Say when you're ready.
1, 3,
Do you want that to come, or do you want to
Let's just take this off, just wait while pads there. Yeah.
Yeah.
1, 3, 1, 2, 3.
And we'll go straight onto the Lucas. Have we had a click both side and check?
Yeah.
Okay, start Lucas.
32.
Okay, and we can get set up for a coach.
You guys need to, we can go anytime from now, so continue compressions. We've got a closed circuit. Happy with that. So everyone else clear, we're charging. Pause.
And
Follow it rhythm. Shock. Shocking. Continue compressions.
okay. Shaz, would you be happy to switch over to our circuit?
Okay, so what we're going to do.
Should we go through it now?
So that's our circuit with
So
our
what we're
end-tidal
gonna do, we're
CO2.
gonna pause that. You're going to put your thumb over the end of the eye gel, and then we're going to put this straight on. So pause, take off eye gel, thumb over, and then directly on with this. Great. Continue compressions. And you're happy with that?
Okay.
No tap allowed on the echo.
Okay, fab. So let's go for IO in, and then we can start giving adrenaline.
We're really grateful to everyone who contributed to the simulations in this video. As you can see, we've had to move rapidly to change our processes, and these videos were taken during workshop sims while we were trying to establish the best way to do things. Things may change as our experience grows, and we'll let you know. If you have any questions in the meantime, please contact either the nurse educators or myself or Sarah Aldington. Thank you.